Hello, class. My name is Justin Handy, and this is Nursing Leadership and Management Laboratory, Nursing 451. And I am doing my Pdsa project on the implementation of ultrasound-guided peripheral IV within my emergency department. Okay, so the Pdsa cycle. So what is the problem? Well, the need for peripheral IV access in anatomical challenging patients is becoming more and more of a problem in the emergency department. Difficult venous access is, which is also known as DVA, is defined as at least 2 failed IV attempts. And patients who typically present to the emergency department with DVA include patients with chronic illness, sickle cell disease, chronic renal failure, diabetes, IV drug abusers, patients who are receiving chemotherapy, patients who are severely hypovolemic, and also patients who just have poor vascular accessibility. So typically when nurses are unable to establish peripheral IV access due to DVA, there are certain rescue methods that can be taken, usually by a physician, which include placing external jugular IVs, ultrasound-guided IV placements, intraosseous device, or central venous catheters, like a central line or a PICC line. So nearly 1 of every 9 to 10 adults in the urban emergency departments have DVA. So quality variance, what is the evidence in contrast to the standard it should be? So, well, failure rates of emergent IV access vary from 10 to 40%. Average time it takes for peripheral IV insertion or cannulation is approximately 2.5 to 16 minutes, and difficult IV access can take up to 30 minutes. So when peripheral IV access is unable to be obtained, it can take physicians approximately 22 to 57 minutes to place a central venous catheter, and that can result in a delay of care. Delays in establishing IV access result in delay in administration of fluid or medications. Patients experience a delay in diagnosis and initiation of treatment. So it can be pretty, serious. So what's the expected outcome? Ultrasound-guided peripheral IV technology can expedite treatment and disposition in an emergency department. Throughput and wait times can also improve, which can positively have an effect on customer service. And we're all about customer service, right? Ultrasound-guided peripheral IV insertion can decrease the need for central venous catheters, CVC, resulting in less central line bloodstream infections. So that's one of the core measures. So that's very beneficial. So who are our stakeholders? Our stakeholders include a lot of people. So implementing an ultrasound-guided IV training program requires collaboration of multidisciplinary team members. So what I did was, what I first did was develop a policy and a competency checklist regarding ultrasound guided peripheral IV insertions, and I did this with help from the emergency nurse educator and the emergency unit manager. I also collaborated with emergency physicians. Um, some emergency physicians will be assisting, teaching the nurses the proper technique of establishing IV access through the ultrasound guidance. And then I'm also currently speaking with a Sonosite rep, which is Sonosite is the company that sells the ultrasound machines, and collaborating with her, and she is going to assist me in that once I set up the ultrasound guided IV training course. She's going to come in and help teach the nurses the proper use of the ultrasound machine, and she also is going to bring in practice blocks to practice the ultrasound guidance with. RCA, the root cause analysis. So what is the existing evidence of the problem? Peripheral IV catheter insertion is considered the second most invasive procedure for patients who come to the hospital. Problems arise when nurses do not have the appropriate vein assessment and technical skills required to establish IV access on patients with no visible or palpable veins. Due to the increasing number of ED visits annually, it is apparent that gaining peripheral IV access promptly is of great importance for improving patient healthcare outcomes and time management. Central venous catheters are usually placed after multiple attempts of unsuccessful peripheral IV insertions. The national patient safety goals, as well as JCO, have determined that the risks associated with placing a CVC outweigh the benefits for most patients. When unable to obtain an appropriate peripheral IV site, serious problems can occur, such as a delay in making a medical diagnosis, administration of IV fluids, medications, and blood products, and vascular complications management. All right, and so the solution and solution implementation. What I did was I created a policy and procedure. I wrote that, and regarding the use of ultrasound guided IV insertion to establish a standard of practice within the emergency department. And let me show you the policy and procedure that I wrote. Here's the policy and procedure that I wrote. Ultrasound guided peripheral IV catheter insertion policy. Purpose is ultrasound guided peripheral IV catheter insertion is a technique that can reduce the amount of unsuccessful IV attempts and ensure visualization of the vessel. It can eliminate delays and frustration and ultimately reduce the use of supplies and staff time. So what this includes is it includes all the equipment that is needed to place a peripheral IV using the ultrasound, and it kind of gives you a step-by-step approach and an approach on how to accurately and most efficiently place a peripheral IV using the ultrasound machine. And I will attach a copy of this. So the next thing is a competency checklist was made for nurses to follow once they have attended the training class. And that is here. So this is the competency checklist that I created. And this is basically a checklist for the nurses to kind of keep in hand while they are doing the ultrasound guided IV, just to make sure that they are doing it accurately and meeting all expectations. And also, they will require 6 successful cannulations that need to be signed off by a proficient nurse or doctor in order to be competent in placing ultrasound guided IVs in the emergency department. So I also scheduled a class that's going to be held on September 8th at 8 a.m. There are currently 15 nurses that have signed up for it, and will be attending the first class. The class will be approximately 2 hours long, with the first hour being lecture and review of proper anatomical landmarks and procedure, and then the second hour will be hands-on training. And a sonocyte representative and the physicians will assist the nurses with the proper technique and use of the ultrasound machine. So nurses are then required to complete the competency checklist and have a proficient nurse or doctor sign them off on 6 successful cannulations before the nurse is considered competent. Analysis. So data collection will be done using a Pdsa spreadsheet for analysis. There will be a specific area in the patient's chart that nurses can document when using ultrasound guidance for peripheral IV insertion. The documentation will consist of including the reason for using the ultrasound guidance, how many unsuccessful attempts were made before using the ultrasound, size of the catheter used, location of the insertion, if blood was drawn, and how many attempts were performed using ultrasound, and if it was successful or not. Data will be analyzed using a StataCorp. Data will be presented as means with standard deviation, medians with interquartile ranges or frequency counts, and percentages with 95% confidence interval. The number of central line catheters placed in the emergency department will be monitored before and after the use of ultrasound guidance, and a cost analysis will be performed. And act. So what solutions will be continued, or what will happen if the goals are not met? So basically, goals are going to be measured through percentage of successful cannulations using the ultrasound. And that's going to be done by reviewing the data that we receive from the charting. And depending on the results of the data, there may have to be a more detailed hands-on training session implemented to ensure competence. There are also some budgetary considerations for personal equipment, including purchasing a training block, which costs approximately $500. And also, our department may need to purchase another ultrasound machine, which costs approximately $30,000. So that concludes my presentation. I hope you enjoyed it, and thank you very much, and have a blessed day.